This is an incredible honor and pleasure for me to introduce Fred Appelbaum. You can see in the sign out there who he is, but and he's going to give a talk based on his book called Living Medicine, and it's a story of our Nobel laureate Don Thomas. But what's going to be missing in this talk is who Fred is. He is decidedly not neurosurgical, so he doesn't talk about himself in the book or here today. I doubt he'll mention himself at all, but he played an enormous role in bringing bone marrow transplantation to the University of Washington. So I'm going to talk about him. I'm going to embarrass him a little. I know him. One of the reasons I know Fred is because our wives, who are much more effective than we are, worked for a nonprofit auction and bought a piano for this nonprofit, and I got to meet him, and it's been a great honor. Probably the best clinical trialist in the entire university. But a little bit about him: he grew up and went to the animal school of the Ivies. He went to Dartmouth, okay, off to then to Tufts Medical School, and trained in internal medicine at the University of Michigan. In the last 2 years, as part of what you do when you want to be a scientist, is you go to NIH. And in NIH, he got very interested in blood dyscrasias, blood cancer. And let me take you back in time to the 70s when he graduated, when he was at NIH. There were over 60,000 people with a blood cancer, and everybody dies. Okay, that's the story. People with lymphoma, leukemia, AML die. Okay, and it was only through the determined effort of people like Don Thomas and Fred Appelbaum that we now have bone marrow transplantation that now you can do as an outpatient. I still can't wrap my head around the fact that you can do this as an outpatient, because even when I trained, it was a horrible treatment, and people died of infections. But Fred was part of that group of pioneers at the University of Washington who took this from a lethal disease to one where most people get cured or at least treated well these days. Fred is the executive vice president of the Fred Hutch. He's a professor at the university. And I thought about Fred when the announcement in April came out that the Fred Hutch Cancer Center is merging with the University of Washington Medical Center, because the whole reason that the Fred Hutch is part of the UW has a lot to do with Fred as his leadership of the Seattle Cancer Care Alliance. He was the head for almost 20 years. He was the head of medical oncology for the University of Washington. He was president of the Seattle Cancer Care Alliance. He's published over 700 peer-reviewed articles on this subject of transplant, of bone marrow transplant. And he has the highest H factor of any scientist I have met, 192. If you're in the 20-30 range, you're pretty good as a professor. 50, 70 even is fantastic. I've never seen anybody with 192. But why is that? Because they developed a system. Fred was responsible for the first report in 1978. When he came here to the University of Washington, he reported the first successful, he proved proof of purchase. He proved that you can transplant autologous cells into somebody and revive their bone marrow, okay? And so that they wouldn't die of the radiation or the high dose chemotherapy. Fred went on, 2013, he became a member. He was elected to the National Academy of Medicine. Many of his papers have more than 5,000 citations to them. He was an amazing figure. Everything, not just the science, not just the fact that he's the best trialist at the University of Washington, but he helped build the social work, the nursing, everything that happened. And just to put it in perspective, 25 years ago when I came here, people flew from all over the world to learn from Fred on how to do this. Okay, I remember one of my colleagues, Irena Slotz from Kinder Clinic, ran the Children's Hospital in Vienna. She learned how to do bone marrow transplant here at the Hutch because that's where everybody around the world came. And so when we go from a 0% survival to now 100,000 people this year will probably get bone marrow transplant. It's impressive. But Fred will not tell you about his role in that. So I feel compelled to point out what a great scientist, what a great friend, what an amazing figure. And not to forget, but he's going to talk mostly about Don Thomas because he's not a neurosurgeon and he won't talk about himself. So thank you very much for what you brought here. Thank you for bringing the Hutch to the University of Washington.
That was over the top. In the mid-1930s, everyone, including chemists and physicists, thought that the atom was indivisible. I should say almost everyone. There were a few people, including Leo Szilard, who hypothesized that if a neutron happened to strike the nucleus of an unstable isotope in just the right way, that nucleus might split, leaving off energy and other neutrons. And then he took it the next step. If you had a lot of that isotope, perhaps a neutron would hit a nucleus, splitting it, leaving off other neutrons, which would then hit other nuclei, splitting those. And you would have a nuclear chain reaction. And if you could harvest that energy, you might be able to have a nuclear reactor, which he patented in 1935, before anyone had ever split an atom. Then he had one other thought. If you had incredibly pure isotope, and a lot of it, packed in a very small area, the nuclear chain reaction would happen instantaneously, giving off an enormous amount of energy, leading to an explosion unlike anything that humankind had ever seen. That idea he kept to himself. Now, Szilard was a Hungarian Jew, and he had left Europe when he saw the rising tide of Nazism sweeping over Europe. In 1938, Otto Hahn demonstrated that, in fact, you could split an atom by exposing it to a neutron. Now, when Szilard heard that Hahn had showed that nuclear fission was a reality and not just a hypothesis, it scared the crap out of him because Hahn was a German in Hitler's Germany. Szilard didn't know quite what to do. So he went to a friend, Albert Einstein. And in a famous meeting, he explained to Einstein the idea that you might be able to make a bomb out of uranium. To which Einstein famously replied, "I never thought of that," which is pretty remarkable. But when he had thought of it, Einstein wrote a letter. He wrote a letter to Franklin Delano Roosevelt, and that was how the Manhattan Project began. Now, the Manhattan Project began very slowly, a total of $160,000 spread out among 4 different laboratories in the United States. But then December 7th, 1941 happened. And when Japan attacked Pearl Harbor, everything changed. Suddenly, the government moved the leading physicists around the country to Chicago, where they together could see if they could really create a sustained nuclear chain reaction. Now, when all these guys showed up in Chicago, they needed a doctor to look out after them because after all, they were going to be fooling around with radioactive materials. And so they picked a second-year resident by the name of Leon Jacobson, who had gone to medical school in South Dakota, had never, ever been in a laboratory, was just there to take care of these docs, these physicists. Well, it turns out that they were very successful in being able to create a nuclear chain reaction. And by the end of 1942, they had done so. They did it under the stands of the Alonzo Stagg football stadium because the stadium was abandoned. The president of the University of Chicago didn't feel that football and academics had a place together. Imagine Anna Mari doing that for the Huskies. I don't think it would go well. And in the fall of 1942, they were able to create that sustained nuclear chain reaction. The stadium is no longer there, but if you take a walk down at the University of Chicago, down the middle of the campus, there is a little plaque on the sidewalk where that reaction happened. And then if you turn around 180 degrees on the other side, there is a sculpture that was done by Henry Moore. It is a bronze mushroom cloud, and that's my wife standing beside it when we visited it. Things went pretty quickly thereafter. In 1943, 1944, they were able to purify uranium at Oak Ridge and plutonium at Hanford, and then they moved to Los Alamos where they constructed the atomic bomb. And as you know, in the fall of 1945, the United States detonated 2 atomic bombs, one over Hiroshima and one over Nagasaki. About 200,000 people were killed by those 2 bombs. 80% of them died almost instantly from the heat and percussion of the blast. But another 20% died after weeks to a couple months. And when they were examined, they were found to be pancytopenic with no platelets and no white cells and severely anemic. And this was termed atomic bomb disease. People wanted to study atomic bomb disease because after the war, nobody was sure that this would be the last atomic bombs that were ever dropped. And so a lot of investigations went into that. And one very important experiment was conducted by Leon Jacobson. Now, Jacobson, who had never been in a laboratory, taking care of these physicists, became interested in the effects of radiation on living organisms. And trying to understand atomic bomb disease, he took mice and exposed them to total body radiation. And the mice abruptly died within a week or 2 with bleeding and infection, just like victims of atomic bomb disease. But if he exteriorized their spleen and shielded it in lead, still attached by an artery and vein to the animals would survive the radiation. And then when other individuals took spleen cells or bone marrow cells from syngeneic mice and transferred them to radiated mice, again, the animals survived. Now, this experiment raised the idea in Don Thomas, who at the time was a chief resident at Harvard, at the Brigham Hospital. And Don surmised that, well, if you could radiate a mouse and destroy a normal bone marrow and replace it, why couldn't you radiate a mouse who had an abnormal bone marrow? And that could be leukemic, or it could be thalassemic, or it could be sickle cell disease, and save the animal and then do the same thing in humans. And so the idea of bone marrow transplantation came to Don when he was a resident, having read these articles. Now, Don grew up very poor in rural Texas. His dad was a general practitioner and would go from house to house in a horse and buggy early on, and then in a Model T Ford. Don, observing his dad, badly wanted to go to medical school, but couldn't because they didn't have enough money. At college, he met his wife, Dottie, and after college, he got a job as a teaching assistant. But then when World War II happened, there was an acute shortage of physicians because so many physicians had to care for the soldiers, both in the United States and overseas. And it's estimated that they needed another 20 to 40,000 doctors. And so the military started paying for individuals' tuition to go to college if they would come back and then serve after college. And so with that support, Don was able to go to Harvard Medical School. And that is where he learned about the spleen shielding experiments. After medical school and serving in the Army, he came back to Harvard as an attending physician, still thinking about this idea of bone marrow transplantation. And when he was a physician at Harvard, a patient was admitted to his service, a man by the name of Richard Herrick. Now, Richard was dying of renal failure. But unlike most patients with renal failure, Richard had an identical twin, Ronald Herrick. And a guy by the name of Joe Murray had been waiting for just such a patient. And Joe Murray took a kidney from Ronald, transplanted into Richard, and that was the very first successful kidney transplant ever performed in the world. Richard recovered, married his nurse, went on and had 2 kids. Now, Don was taking care of these individuals, and that gave him another reason to want to pursue bone marrow transplantation, because Don figured if you did a bone marrow transplant before you did the kidney transplant, then the immune system of the recipient would be the same as the donor, and that kidney would never be rejected, and you wouldn't have to be on immune suppression. So not only would bone marrow transplantation provide a way of curing all bone marrow diseases, but it might make solid organ transplantation a reality. So Don wanted to pursue this idea. And so he went to his boss. His boss was a guy by the name of Sidney Farber from Dana-Farber Cancer Center. Farber said, absolutely not. That is an absolutely ridiculous idea. Everyone knows that you cannot transplant tissue except in the very rare circumstance of identical twins. It's against basically the laws of nature. Now, Farber wasn't wrong. People had been trying to transplant skin, noses, ears forever. I mean, literally 1,000 years, and had never been able to do it. But Don knew of one exception. This is a free Martin cattle. Now, if you don't know what a free Martin cattle is, this looks like a male, but isn't. It's a female. Free Martins occur when a cow has fraternal twins, one male and one female. Now, in cattle and in deer, the placentas frequently fuse, and so there's mixed circulation. And because of the mixed circulation, the androgens from the male fetus masculinize the female, and so she is born sterile and never gives milk and remains androgenized for the rest of their lives. Now, the most amazing thing, though, about free Martins is if you look at their blood, it is a mixture of both male and female blood cells. And you can take a skin graft from the male and transfer it to the female, and she will never reject it. Somehow being exposed to antigens in utero leads to lifelong tolerance, something called neonatal tolerance. The understanding of neonatal tolerance is why Peter Medawar got the Nobel Prize in 1960. Now, Don knew about this, and he and another guy, Farabi, hypothesized that the introduction to the host of bone marrow cells from a prospective donor at a time when the immune system of the host is reduced by radiation or other means to a fetal-like stage of acceptance might allow for the development of tolerance and successful engraftment. And that's what Don wanted to try to do. Now, Farber was not going to give him any space to do it. Farabi, who had been one of Don's colleagues in Boston, had since moved upstate New York to Cooperstown. And when Don couldn't get any space to do his research at Harvard, he quit his position at Harvard and moved to Cooperstown to work with Farabi. So in 1956, he leaves Harvard, he goes to Boston, and he goes to Cooperstown, and immediately they start trying to do bone marrow transplants. Within the first year, they do 6 transplants, and none of them take. except transiently, one of them, there's a slight increase in red cells, but all 6 patients quickly die. Now, Don did not try to match. There was no idea of how to do histocompatibility matching. He was getting the marrow cells from any place he could. In fact, the first transplant they did, they took the marrow from a stillborn fetus. In another case, they took it from someone who had a rib removed for a thoracotomy. But he was still trying to do it. And this paper did get published in the New England Journal showing that you could infuse the bone marrow cells intravenously without harm. And there was very transient engraftment in one case. And in trying to explain why he's doing it, Don wrote, and this is in the, which I liked in the discussion of the paper, in an atomic age with reactor accidents, not to mention stupidities with bombs, somebody is going to get more radiation than is good for him. If infusion of marrow can induce recovery in a mouse or monkey after lethal radiation, one had best be prepared with this form of treatment in man. The leukemic patient who needs radiation in bone marrow and the uremic patient who needs a spare kidney are the people who deserve immediate consideration. From helping them, one will be preparing for the atomic disaster of tomorrow, and it is high time one did. That was in the discussion in his New England Journal paper. He continues to try to do transplants in humans, but just a few of them. And he shows that you can give bone marrow safely intravenously. You sometimes see a little bit of engraftment when you give high enough TBI doses over 800 centigrade. And you can't give more than 2,000 centigrade or patients die with acute liver failure. And he did do a couple transplants in twins that had leukemia and showed that there was very temporary remissions, but only very temporary. And so he realizes he has a lot of work to do to ever make marrow transplantation work. And so he goes and starts working in a canine model. Now he picks dogs to work in because they're an outbred species. They come in litters, and they're big enough that you can do repetitive medical interventions. And in dogs, he shows that you can give a dog a total body radiation of up to 1,600 centigrade. And if you take bone marrow out beforehand and then give it back after the radiation, the dogs can recover. You can freeze bone marrow. You can use peripheral blood. And if you take litter mates and give them post-transplant methotrexate, occasionally you can see long-term engraftment. This is Honest John, published in 1959, who survived 4 times the normal dose of lethal radiation, was given litter mate bone marrow, methotrexate post-transplant, and survived. But this only happened occasionally. In most cases, it did not work. And so in 1960, Don is invited to give a talk here in Seattle by Clem Finch, who was the old head of hematology. And during his talk, he's telling about the stories of trying to do transplantation and the fact that when he does it in people who don't have identical twins, the graft is always rejected, or occasionally they die of infection. In identical twins, the leukemia always comes back. And after he finishes his talk, a young resident comes running up to the stage. He says, "I have the perfect patient for you." This guy was Marino Robbins, and Robbins says, "I have a little girl, 6 years old, who is dying of aplastic anemia and has an identical twin." And Dodd said, "That's great." And so Robbins says, "Well, let's go do a transplant." Now, mind you, Don is visiting here. He certainly doesn't have a license to practice in the state of Washington. He certainly doesn't have credentials to practice here. And he certainly does not have a protocol with an IRB. But times were different then. And so Don talks to the family, and they take Barbara, to the normal twin, to the operating room. They take bone marrow from her hips and shins, 44 sticks. They take the marrow, they infuse it into Nancy. 2 weeks later, Nancy's counts are recovering. 2 months later, she's back in school. Now, I can tell you 64 years later, Nancy is still doing well. She's retired from a school nurse. Her sister Barbara is also doing well. They live in Seattle, outside of Seattle. I talked to him about a month ago. Nancy, who is now 70 years old, is certainly the first person on the face of the earth ever cured with a bone marrow transplant. Now, when people read about this, they say, "Oh, maybe we should be trying to do transplants." Over the next few years, there are probably 200 transplants performed around the country. And except for the rare patient with aplastic anemia and identical twin, every one of these patients dies. No successes. And so people are leaving the field. But Don is not ready to quit. He still wants to try and make transplantation work, and he's had this occasional success in a dog. In 1963, he decides that Cooperstown doesn't have enough of an academic environment around, so he decides to move to Seattle. And he's joined here by Bob Epstein, Reiner Storb, and Dean Buckner. And together they are working in the dog model, trying to figure out how to do transplants so that it works every time. Now, at the same time, there are advances being made in human histocompatibility. So HLA is being discovered, and the way to do HLA typing is being developed. Jean Dassé, along with Snell and Benacerraf, win the Nobel Prize for developing the principles of how to do HLA and what it all means. So Don and the group in Seattle are reading this information, and so they mimic the typing that Dassé has done in HLA to do so-called DLA typing, dog leukocyte antigen typing. And when they do that, they can show that if you take a dog and you radiate it with 1500 centigrade, and you infuse bone marrow that is mismatched, the dogs always die. They don't engraft. But if you do the same thing and you take DLA matched marrow after the radiation and they give them post-transplant methotrexate, every one of the animals recovers and becomes a long-term survivor. With that advance, Don is ready to go back and try marrow transplantation in humans. He writes a grant, gets funding to remodel a small ward on the 7th floor of the old Seattle Pacific Health Hospital, now known as PacMed, and starts doing transplants. The first year in 1969, they do 6 transplants. None of them get out of the hospital. They all die before they can be discharged. The next year, he does 9. 2 are discharged. The next year, hearing that some have been survived the transplant, it goes up to 18. By 1974, the team has done 100 transplants, and this is the result. Now, there are 2 parts of this curve I want you to look at. The first is the fact that there are about 14% of patients who were at death's door. They had end-stage leukemia who have been cured. So they've cured otherwise incurable patients. But the other part of the curve is here. These patients are not getting out of the hospital. They are dying of infections. They are dying of graft versus host disease. They are dying of kidney failure and of hepatic failure because they are incredibly sick when they come. And then when you give a patient 1,000 rads of radiation and cytoxin, they get even sicker. At the time, there were very few antibiotics. The only antifungal was amphotericin. There were no antivirals whatsoever. There was no way to feed these individuals who were starving to death. It had horrible mucositis. And so Don starts to amalgamate a team of physicians, including infectious disease experts, that teach us how to prevent bacterial infections. He houses the patients in laminar airflow rooms. He collects granulocytes from the donors and from the general population, and platelets from everyone, including most of the staff. And suddenly we're starting to see that the patients are able to survive the early days of the transplant. He recruits Bob Hickman, who is a nephrologist at Children's, and Bob learns how to develop a long-lasting silastic catheter so that we can start to feed the individuals intravenously. And suddenly the patients are starting to survive. And we're going from 90% mortality to an 80% mortality to a 70% mortality because of the team of physicians that are helping to support the transplant patients. And over the next decade, there are a number of firsts that really have changed the field of marrow transplantation. As Rich mentioned, we were able to do the first autologous transplant. So for patients with lymphoma where the bone marrow was normal, we were able to take out their bone marrow, cryopreserve it, give the patients high-dose chemotherapy, rescue them, and show that patients who had otherwise incurable lymphomas could now be cured. This year, there'll be 30,000 autologous transplants performed worldwide. We showed that, as I'll show you in a second, we could do transplants much more successfully if instead of doing it in end-stage leukemic patients, we started doing it in patients who were in first remission. And we started showing that we could cure other hematologic malignancies with transplantation, including myelodysplasia. Hodgkin's disease. And we did the first unrelated transplants, the first cure of thalassemia, and the first cure of sickle cell disease. This is the paper that was the first successful use of autologous marrow transplantation to treat malignant lymphoma. As I said, that we did that in 1977, published it a year later. These are the results with the first group of patients that were transplanted in first remission. Instead of having that 12% cure rate, now the cure rates are getting up to 60% if we do the transplants earlier on in the course of disease. Now, at the time, we could only do transplants on individuals who had matched siblings. The chance that any two siblings will be matched is 1 in 4, because it's on chromosome 6, and you get 1 chromosome 6 from mom, 1 chromosome 6 from dad, 1 in 4 that they'll be the same. Unfortunately, because because the size of the average family, that means that only about 1/3 of individuals, and it's getting a little less now, will have a matched sibling. And so if you didn't have a matched sibling back then, there was nothing we could do. We couldn't do a transplant. That changed in 1979 when Bob Graves knocked on John Hansen's door. Now, Bob didn't call ahead. That wasn't his style. He just showed up in Seattle. And he shows up at John Hansen's door. He knocks on it and says, "I have a problem." And John says, "Come in. What's the problem?" He says, "I have a daughter who's going to die of leukemia. And the reason she's going to die is because she has leukemia, it's recurred, and none of her sisters match." Now, Bob was a veterinarian, but also had a very large ranch in Colorado, a milk ranch. And because he was a veterinarian, he could read the literature. And he told John, he said, "Look, I know that HLA is very disparate, but I also know that Laura has probably the most common HLA type in all Caucasians. Now, by common, that means that maybe 4% of people have the same type. So it's not hopelessly rare. So, and I'll bet you could probably find a donor for Laura if you tried." And so John thinks about it and says, "Well, it's possible. We've never done an unrelated donor transplant. But it's not up to me, it's up to Don Thomas." And so Bob says, "Well, let's go see Don." I mean, that's the kind of guy Bob was. And so they go down, talk to Don, and Don says, "Well, if we could find a donor, maybe we could try it." Turns out that most of us had been HLA typed at the Hutch by that time because we were serving as platelet donors. And John Hansen goes through his files. And by files, I mean, a 4x6 box with cards in it, that kind of file. And in that file, in fact, it turns out that a technician on the 3rd floor matched Laura. And so we go to the technician and ask if she would be willing to donate bone marrow, and she would. We do the transplant, and it goes swimmingly. Laura is discharged. She never gets any graft versus host disease. She recovers entirely. Unfortunately, her leukemia came back 2 years later. But Bob was so taken by the fact that we could try this and do it that he made it his campaign in life to try and create a registry. And when he goes forward to try and do this, he talks to everyone, and people say, "It's an interesting idea, but HLA is so disparate, that's probably a bridge too far." Well, about a year later, I get a call from a friend of mine in Bethesda who has a patient he wants me to see. From the Bethesda Naval Hospital. And the patient comes out to see me. He has lymphoma. And the patient's name is Elmo Zumwalt III. And so I'm taking care of Elmo, and his dad comes out as well. Now, his dad is Elmo Zumwalt Jr., who was Admiral Zumwalt. He was in charge of all naval operations in the Pacific during the Vietnam War. And to make the story a little more poignant, it turned out that his son, my patient, was a PT boat captain in Vietnam, and it was his father that ordered Agent Orange to be used as a defoliant along all of Vietnam. And so the admiral and his son both were convinced, and probably rightly, that the Agent Orange was what caused his lymphoma. By the way, Agent Orange, the reason Agent Orange was causing cancer wasn't the Agent Orange itself, it was because it was contaminated with dioxin, and the dioxin was the carcinogen. So anyway, the admiral says, "Well, I'm so taken with what you're doing. Is there anything I can do to help?" And so Don says, "I have an idea. Yes, you can help." And he introduces Bob Graves to the admiral. And together they get a very large appropriation from the Navy to form the National Marrow Donor Program. And that's how the National Marrow Program became what it is. And Bob was the first chairman of the board, and the Admiral was the vice chairman. And I will tell you that today, starting with those two guys, there are 40 million people who have been HLA typed and entered into registries around the world to serve as donors for patients who need a transplant. And with that advance, we can find a donor now for just about every patient in need. So that was the very first unrelated donor transplant that occurred in 1979. The first thalassaemic ever cured was cured here in Seattle in 1980. As Rich mentioned, people were coming to learn the craft of marrow transplantation, including a physician from Italy who came and learned how to do a transplant. And while she was here, we were talking about the possibilities of doing transplants for thalassemia. We had shied away from that because patients with thalassemia could live for 10, 20 years, and the transplant could be fatal. And so it really was tough to balance the risk and benefit of it. But by this time, we figured the mortality associated with transplantation was down to probably around 10 to 15%. And with that mortality rate, as long as patients and their families had good informed consent, it was not unreasonable to try it. And so one of the individuals who trained here went back to Italy, where thalassemia is quite common, and was presented with a patient who had thalassemia, whose two siblings had already died of thalassemia. And so the family knew very much what thalassemia was all about. But they had a third sibling who did not have thalassemia and who was HLA identical. They flew to Seattle. We performed the transplant in 1980, and Luca now is 44 years later, doing well as a business person back in Italy. As transplantation grows, by 1990, Don is awarded the Nobel Prize, which incidentally he shared with Joe Murray, the guy that did that first kidney transplant that helped inspire Don to proceed with transplantation. Now, since 1990, there has been a great deal of progress. He got the Nobel Prize in 1990. Now that's 34 years ago. And transplantation continues to increase in frequency, both autografting and allografting. It's estimated that worldwide, there probably are about 100,000 transplants performed, and that all started here in Seattle with Don. And things continue to get better. This is a paper we published recently, I guess now it's a year and a half ago. And it looks at the survival of patients who are transplanted for leukemia. Now, most of these patients have failed first-line therapy, and they're getting leukemia, they're getting a transplant as salvage therapy. And as you can see, this is about 1,400 patients we transplanted in Seattle between 1993 and 1997. This is a decade later, 2003 to 2007. This is a decade later, 2013 to 2017. And these are the raw data. The patients we're transplanting now tend to be older and have more comorbidities. And so if you were to risk adjust this, the advantage would look even greater than it does here with the raw data shown. Now, why is this happening? That, of course, could be a whole textbook of transplantation. It would not be, probably I'd bore you to tears if we went through all of that. But I will show you that if you look at just about every form of morbidity that's associated with transplantation, whether it be the development of CMV disease or fungal disease, or having renal failure, or having liver failure, or having graft versus host disease, or relapsing, for every year, it keeps getting better. The incidence is reduced. And it's reduced because of a whole team of individuals who are doing randomized trials proving that ganciclovir prophylaxis can prevent CMV disease, proving that fluconazole prophylaxis can eliminate a bunch of fungal disease, showing that voriconazole is better than amphotericin and certainly much easier on your kidneys. Showing that deoxycholic acid can prevent liver failure, and showing that we can do better job of HLA typing if we do it on a molecular basis. And so for all these reasons, and every one of these is read by a whole team of individuals that have made transplantation better and better. And of course, we continue to do research in all of these areas. if you were to ask what are the general topics of transplantation research right now, they include trying to develop a better preparative regimen. Instead of giving systemic therapy to the entire body, can we target therapy to try and make the preparative regimens better? Can we eliminate graft versus host disease? And can we prevent post-transplant relapse? And just to show you very briefly examples, we are now using radio-labeled antibodies to do the preparative regimen so that we can take astatine, for example, an alpha emitter, hook it up to an antibody that only reacts with hematopoietic cells, give that intravenously. We're radiating the bone marrow and the spleen and the lymph nodes, but excuse me, but we're not radiating the lungs or the liver. And so we're getting much less toxicity and more efficacy by doing that. In terms of getting rid of graft versus host disease, we have learned that the majority of graft versus host disease is caused by naive T cells as opposed to memory T cells or educated T cells. If we take out all the T cells from the marrow inoculum, then we do two things. We make the patient much more susceptible to infection. And we also eliminate, what I'll show you in a second, is a graft versus leukemia effect. But by only eliminating naive T cells, we can maintain this memory of infection so that the patients aren't as much at risk. And as shown here, we can virtually entirely eliminate graft versus host disease. This is 150 patients that were published by Marie Bleakley last year in JCO. And you can see the incidence of significant grade 3 graft versus host disease is now, what is 6% or less. So making really real headway in getting rid of graft versus host disease, so that our survival here in leukemic patients is 77% at 5 years. And as far as post-transplant relapse is concerned, one of the most important observations that we made when we're doing transplants, and we made all the way back in 1980 or so, and that is that the chance that leukemia recurs after a transplant is much less if a patient is transplanted from a sibling than if they are transplanted from an identical twin. So if you're transplanted from an identical twin, the chance that the leukemia comes back is much higher than if you get transplanted from a HLA-matched sibling and don't have any evidence of graft versus host disease. But if you get graft versus host disease, you get the chance of recurrence is even less. And the only way to explain that is that the immune system coming from the donor sees the leukemia as being foreign and rejects it. And it sees the leukemia as being foreign and rejects it more avidly than it sees other tissues. So leukemia is a better target than the skin or the GI tract, which is why even if you don't have any evidence of graft versus host disease, the relapse rate is less than it is with syngeneic. But if you get graft versus host disease, relapse rates are even lower. Now, of course, what we want to do is harness that power without having to pay the price of having graft versus host disease. And so what we have done is, first, we have recognized that there is a GVL effect. And then we found that some patients who relapsed after a transplant, if you just took donor lymphocytes and did nothing more and infused them, the leukemia would go away. It didn't always work, and it also sometimes caused graft versus host disease, but it just showed you that the immune system could get rid of leukemia. And then we showed that you could successfully transfer immune cells from donor to recipient. And we started doing that with viruses. So we showed if you took virally specific CMV T cells, isolated them, grew them in vitro, you could give them to the patient and protect that patient from developing CMV disease or get rid of CMV disease. And then we started isolating the T cells that see the leukemia. And finally, what we're doing now is instead of trying to isolate those cells, we're taking the patient's own T cells out. We're putting in receptors that see the leukemia, growing those cells and using those cells therapeutically, so-called CAR T cells. And so the idea now is that what we're doing is we're taking from the patient, or we could also do it from the donor, taking lymphocytes out, we're selecting the T cells that we want, we're transducing them with a receptor that sees the leukemia, and then we're growing them and we're giving them back to the patient. so-called T cell therapy. Now, that was started, it's a direct line from observing the graft versus leukemia effect, showing that you could transfer T cells. The first people that did that were here in Seattle, Phil Greenberg and Stan Riddell, and then doing the very first CAR T cells. The first generation of CAR T cells were done here with Brian Till. Others have shown better ways to make those T cells, Carl Jude and others, but now it is turned into something that is quite successful. There are now 6 products that have been approved by the FDA to treat leukemia, 4 of them for ALL, CLL, lymphoma, and 2 of them for multiple myeloma. And so not only are there 6 FDA-approved products, but last time I checked on clinicaltrials.gov, there are over 1,000 clinical trials looking at CAR T cells. And not all of these are in hematologic malignancies. Actually, half of these are in solid tumors, including, and this is probably the only thing relevant to what you guys do, there are now CAR T cell trials going on in brain cancer. There are at least 33 CAR T cell trials, including one going on here in Seattle, where people are targeting, and these are some of the antigens that are being targeted, including HER2/neu, B7H3. These are probably familiar to many of you as potential targets on brain cancer. Now, we are seeing responses in some patients. They're not dramatic, and they so far have not been enduring, but it's progress. And, you know, it takes one step at a time, how those cells endure, how they continue to migrate, how they maintain their efficacy in vitro, in vivo are all questions. But certainly one of the legacies of Don Thomas is not just the 100,000 transplants that are performed every year, but the development of targeted T cell therapy. A second legacy of Don is gene therapy. The first patient ever cured of sickle cell disease was a young girl by the name of Kimberlyn George. Now, Kimberlyn showed up in an emergency room with what people thought was a sickle crisis, but when they looked at her peripheral blood, they saw both sickled red cells, but also myeloblasts. She had AML, and which is why she was having a crisis. She was treated with chemotherapy, but the AML, of course, wouldn't be cured just with chemotherapy, and so she had a bone marrow transplant, not to cure her sickle cell disease, but to cure her leukemia. But in curing her leukemia, we cured her sickle cell disease as well. That was back in the 1980s. Well, now what we can do is we can take bone marrow out, and we can correct the gene that caused sickle cell disease and do an autologous transplant, giving that bone marrow back and cure sickle cell disease. Another way that we can cure sickle cell disease is by, you know, when you're in utero, you make fetal hemoglobin. And the reason the infant makes fetal hemoglobin is because fetal hemoglobin binds onto oxygen better than adult globin does, because the fetus has to steal oxygen from the mother. When you're born, you switch from fetal to adult hemoglobin. And we now know the gene that causes that switch, and we can ablate that gene, reestablishing fetal hemoglobin, and therefore getting rid of sickle cell disease. And that's been done with CRISPR. And now CRISPR has just been approved, and you might have seen in the newspaper last week that it was also approved not just for sickle cell disease, but for thalassemia. FDA just approved that last week. This is the first patient that was ever treated with CRISPR to cure sickle cell disease. Her name is Victoria George, and 5 years later, Victoria is doing well. She says it's the cure that she had always been dreaming of. A second legacy of Don Thomas. A third legacy of Don Thomas is the cure of diseases of immunity. This is the first individual ever cured of AIDS. The so-called Berlin patient, Timothy Ray Brown from Seattle. Again, he had AML and was transplanted for AML, but the doctors wisely chose a donor who had an abnormality or a polymorphism in CXCR4. A delta 32 deletion, which makes the CD4 cells impermeable to HIV. And so by using a donor that had that polymorphism, the HIV went away. He's been taken off of all immune suppression, and the HIV stayed away. Tim did eventually die of myelodysplasia about 13 years after the transplant. but was the first person ever cured of HIV. And now in the Hutch, what we're doing is we're taking out lymphocytes from patients and we're rendering them impermeable to HIV and using that as a possible therapeutic approach. Another part of Don's legacy is the development of other stem cells. Now, bone marrow transplantation was the first stem cell therapy, but it won't be the last. There are stem cells now being transplanted for Parkinson's, for multiple sclerosis, for ALS, for macular degeneration. And last year, for the first time, another stem cell therapy was approved by the FDA, this one using islet cells for the cure of diabetes. But marrow transplantation was the first, and as I say, it certainly won't be the last. And finally, one of the reasons that Don wanted to do marrow transplantation was to allow for solid organ transplants. Now, that has been slow to come, but it is now happening. This was published in the New England Journal about 6 months ago. 3 individuals who had a congenital disease of the kidney were transplanted from their parent using first bone marrow and then got the kidneys and have now totally recovered and doing fine. I was just down at Stanford talking with the group there. They have a program where they are doing transplants from donors before kidney transplant. They've done 27 of them, and 24 of the patients are now off of all immune suppression and have not had any change in their kidney function. Their kidneys are functioning fine, even though they've been able to come off of all immune suppression. And you probably know better than I do that the average life of a kidney is about 10 years after transplantation, which makes it very difficult because there's such a shortage of solid organs. If you can get rid of that problem, what a boom that would be for all of us. And so when I think of Don, obviously, I think of his legacy as being enormous in the 100,000 patients that are getting marrow transplantation every year. But it's not just that. It's the development of immune therapies using adoptive T cells. It's the development of new therapies for gene therapy. It's the development of new forms of therapy that can cure all immune deficiencies, new stem cells, and also the possibility of making solid organ transplantation a possibility. Now, if you ask me what was unique about Don, of course, I could go on for another hour, but it really was just, I think, 3 things. Number one, he was focused. When we formed the Hutch, other cancer centers were developing therapies for all forms of different diseases. People were interested in breast cancer, lung cancer, colon cancer, and rightly so. Don only cared about one thing. He cared about marrow transplantation work. And so everyone that was recruited to the Hutch in the early days were with that singular goal. So it was focus. And the second thing that Don had was incredible persistence. It took him 10 years to go from his first failed transplants to the first successful transplants, from 1956 to 1957 to 1967. And finally, Don was incredibly focused on developing a team. It took not just the oncologists, it took the infectious disease doctors, the GI doctors, the surgeons, the nurses, the support staff to make it happen. And without that, we certainly would not have been successful. And so as I end my talk, I just want to also thank all the mid-level providers, the nurses, the pharmacists, dietitians, schedulers, social workers, and all the other members of the team that made this possible. And thank you for your attention, and thanks for the invitation to talk to us.
That was absolutely amazing. And I want questions. There got to be lots of questions. Can you, I'll ask a question. You're all stunned because you can't believe that this
7
happened.
a.m. is what the problem is.
No, they've already finished an operation. You can't believe that this happened and it happened here. What brought you? You're a young NIH investigator, and someone calls you up, and you're not from Seattle. Why come here?
My story was that I was a second-year medical student in Boston, and we got a mentor to take us around on the wards And my mentor was this wonderful woman by the name of Jane DeForge, one of the real early champions of hematology. And this is a time when, in the 70s, there were not so many great women leaders in medicine at the time. And Jane was just astounding. And she was taking us around the ward. We were trying to learn how to listen to lungs and palpate abdomens. And she took me, there were 4 of us with her, and took us to bedside. And there was this guy lying there, a Red Sox fan, because I could see he had the helmets up, and he had leukemia. And Jane was having us learn how to palpate a spleen. And while we're palpating the spleen, Jane happens to mention this therapy, bone marrow transplantation, that was just being tried for the first time in 1970. And she just says, we don't know, it's really early, but it really is very exciting. And I don't know why. And it's a mystery why any of us end up where we end up, why we become neurosurgeons, or why we go into whatever field it is. Something, it's like Velcro, something just happens. And so I started reading about marrow transplantation after Jane talked about it. And it just seemed like such an exciting area, both because there was so much unknown about it, but the potential seemed so enormous, what could be done. And I also like the idea that it wasn't just one organ, it was sort of a systemic problem, and that appealed to me, as did the acuity of care. Some people like more chronic care, some people like acute care. I was more prone to the latter. And so I just kept reading about it. Obviously, if you read about it in the early days, Don was, it was all the early day stuff was coming out of Seattle and Don. And so when I was at the NIH and published my first papers, one day the phone rang, and it was Don Thomas asking me if I was interested in interviewing for a job. And it was like the heavens opening, right? So I came out, and that's why I came here.
Thank you. Questions? Anything? Bay?
Yeah, thank you. Well, what an amazing talk and context for all of us about the trial that's happening in the world. I'm appreciating that that's a very different time. I wonder if you could talk a little bit about how government's funded, particularly when it's.
I'm sorry, how?
Funded.
Yeah.
When its progress is limited at the beginning.
Right. That's a really an interesting question. One of the questions is, could you do this now, right? When Don started, he did write a program project grant in the 1960s, one of the first program project grants, and did get it funded. And that provided some money for the nursing, for the nursing, and a little bit of physician salary. Incidentally, when Don retired, I took over that grant, and that grant has been continuously funded. That program project grant has been continuously funded from the NIH for well over 55, maybe 60 years. So it might be one of the longest running grants that they have.
$50 million, right?
Well, no, actually, it keeps getting smaller is what happens with the NIH.
Oh,
they keep cutting it.
Initially, you were refunding it for 50.
It was a big grant early on. It keeps getting whittled down. But the other thing was that nobody ever questioned the reimbursement of the patients who were being transplanted. So, back in the 60s and 70s, if a doctor ordered something, the insurance company paid it. The doctors were deciding what the patient should get, not the insurance companies. And so during the 60s and 70s, the patients were being billed, their insurance companies were being billed, we were being paid, and that was enough with the one program project grant to support the clinical studies. Now, once the clinical studies started coming about, then other people came in, and Joel Myers, infectious disease people, and everyone else that worked with Don would, of course, write their own R01s to support it. And we were pretty successful in that grant funding. We also, there was a small amount of philanthropy that from grateful patients, but the majority of it was because insurance companies did not bulk at reimbursing for what would have been, today people say, well, that's not a clinical trial. You have to get approval, and you may get refused for some of the costs.
So,
Yeah. Yes.
okay, well, a few more questions, Jeff, and then
Well, my
Louis.
question, how are these going to be successful in being disseminated, these therapies that are probably expensive, may be viewed as aggressive? You told the thalassemia story, so diabetes, for example, kind of imagine how in 5 years we're going to get that to be commonplace. It's like a lot of people with a lot of money.
Yeah, it is. So I'll give three answers to that. The first is that it is expensive, and the bill for thalassemia transplant for the gene therapy for thalassemia is probably going to be in the range of $2 million. But if you look at the cost of repetitive red cell transfusions and chelation and everything that goes with it, it turns out to be hard to believe, but it turns out to be cost effective. But it's a big price all at once. And of course, one of the problems is that a single insurance company is going to say, hey, you're asking me to pay the $2 million for something that is not going to save me where they're going to be in 20 years. It's going to be saving someone else in 20 years. And so that's an issue that's coming up. But nonetheless, it will be, for people that have insurance, it'll probably be covered. If you don't have good insurance, or you're from a state that doesn't have good coverage, then you may be in difficulty. The second thing, just briefly, is that, when I've been around, fortunately for a long time. And when we first were talking about using monoclonal antibodies, the way we were growing monoclonal antibodies is by injecting the cells into the abdomens of mice and tapping their abdomens for their ascites and purifying the antibody out of those ascites. It costs about $1 million for a gram of monoclonal antibody. And people said monoclonal antibodies will never be a therapeutic. It's just too expensive. And yet, if you look at the list of medicines today, monoclonal antibodies make up half of the top 10 selling drugs in the United States. So if something works, people will figure out a way to make it less expensive. And finally, these gene therapies, and there are people at the Hutch very actively involved in this. We will not have to take out the bone marrow and do the gene therapy and give busulfan and do the autologous transplant. Within 5 years, we will be injecting a vector intravenously and being able to infect and transform the cells in the patient's own body without ever having to do any of that. And basically, it'll turn out to be a single injection from a syringe and not a whole big procedure, which will make it accessible worldwide.
Last question, Louis.
Just changing gears a little bit, and sort of looking more on spotlighting the system of Fred Hutch more than your unbelievable presentation. Sometimes our greatest weakness is our greatest strength, and vice versa. And at the Fred Hutch, it seems that that focus on lymphopoietic disease and hematological disease has been an amazing source of strength and international recognition and patient care, but it also created a ceiling, where it isn't known for other solid organ tumors. Even obviously the expertise is all there. But even in our own community, sometimes the Fred Hutch isn't necessarily, the go-to place for certain types of cancers. What is the future of the Fred Hutch going to look like towards addressing that? Is it going to continue this focus that was, a legacy that you've inherited over many decades, or is it going to try to become a Dana-Farber or an MD Anderson or something?
Well, it's a great question. I will tell you that in 30 years ago, when I became head of the division, the first thing that our board told me and our external advisory board said, you guys you may be making buggy whips if all you're doing is taking care of leukemia and transplantation. You got to diversify. And we have been doing nothing but that ever since over the last 30 years. We now have very robust programs in prostate cancer. We have probably the best prostate cancer program in the country. Our program in breast cancer is getting much stronger, and in lung cancer. So we are And Tom Lynch is absolutely 100, he's a lung cancer doc, and he's absolutely 100% for that. Now, it is, of course, interesting that once you become known for something, it's tough to shake that reputation. And you wouldn't want to become worse at leukemia after all. So you still want to be the leader in transplantation and the hematologic malignancies, but it sometimes can overshadow some of these other accomplishments. But, you know, one of the other things is that the Hutch can't do it alone. We don't have operating rooms. We don't have surgeons. We don't have, you know, radiotherapy to speak of, which is why this merger between the Hutch and the university for our comprehensive cancer center is so incredibly important to allow us to try and achieve the same level of accomplishments in these other tumors that we've been able to do in hematologic malignancies. With leukemia, you know, we didn't have to rely on a surgical colleague, but in these other tumors, you absolutely do. So you need these other modalities, and we're partners in this if we're going to make it work.
It's a wonderful, wonderful question, wonderful answer for all of us wondering, where is this going? You're mapping it out. So it's up to you all, okay, to figure out what that's going to look like for brain tumors and so on. That was fabulous, Fred. Before, I know people have to get to the OR, please sign the picture out there. I don't know if you will wear this publicly, but you're now a neurosurgeon.
Oh,
okay.
Fantastic.
Something you probably never wanted to be. But anyway, thank you, Fred. That was spectacular.